Good afternoon, AUS members, guests, and sponsors. Thank you for joining us for this webinar, ASC Quality Reporting Demystified. This is Mike Romanski. I've had the privilege of serving as AUS's Washington counsel for almost 30 years. I can state unequivocally that this new quality reporting program, with respect to which claims data reporting will commence just 3 months from now on October 1, is the most significant ASC regulatory initiative advanced by CMS since the establishment of the Medicare ASC payment system a quarter of a century ago. Compliance with the requirements of the program will impact quality, payment, administration, and operations within our ASCs. For over 3 years, AUS has been lobbying on your behalf to ensure that this program makes sense from a policy standpoint, and that it is no more administratively burdensome than necessary. Today, though, we're turning our attention to ensuring that ophthalmic ASCs, that all of you understand just what is contemplated by the government in the multitude of regulations, instructions, guidances, and transmittals that have hit the streets just the past couple of months so that you can adequately prepare within your centers. I'd like first to recognize the very special contributions of AmSurg and Hoya Surgical Optics to the development and presentation of this webinar. Without the financial support of these friends in industry, we would not be here today. First of all, if we have any problems, use the help button on the audience console and the webcast tech will get to you right away. You may also use the Q&A area to send a message to the technicians. If your screen becomes locked, PC users use F5 to refresh the screen. Mac users use Command-R. There are a number of documents and forms that will be referenced throughout the presentations. Should you wish to download them, simply click on the green file folder at the bottom of your screen. Among the documents there will be a copy of the slides that are presented today. We're going to ask you to participate a bit in some follow-up with respect to this program. You will receive a very simple and quick to complete survey tomorrow or the next day. Please take that time to complete it and get it back to us. Why is this important? Well, we're planning a second webinar on quality reporting later in the summer, late August, early September, and we need your feedback to know just what to cover. Stay tuned for information on when that will take place. We will also keep you posted through AUS Update Onlines and other correspondence as well. And should you need any help with respect to any of these issues, always feel free to contact me at mromanski@us.org. Our faculty today is perfect for the subject matter. Regina Bohr and Kathy Wilson will present from two perspectives. Regina, president of Progressive Surgical Solutions and a former ASC administrator, has consulted with literally hundreds of ASCs on Medicare survey issues, quality reporting, and virtually every other issue related to quality, management, and operations in ophthalmic ASCs. She's been active in AUS educational programs for 2 decades. Kathy Wilson is the vice president for quality and risk management at AmSurg. AmSurg is the largest ASC management and development company in the world with 227 centers, 36 of which are exclusively ophthalmic. Kathy brings a special expertise to this program today in that many of AmSurg's centers have already been engaged in formal quality reporting activities. And now on with the show. I'm turning things over to Regina.
Thank you, Mike. First, I'm going to just review the objectives. Our objective today is that by the end of this presentation, the attendees will be able to describe the components of the CMS mandatory quality reporting program for ambulatory surgery centers, identify the reporting periods and initial payment years affected, define the quality measures and reporting mechanisms, and identify tools and resources, of course, to assist you with implementation and compliance. We're going to talk a little bit, I'm going to start by just giving a little bit of background. Then we're going to go into the specific quality measures, the reporting methods and the time frames, the safe surgical checklist use, volume data reporting, implementation tools and resources, and of course we'll have plenty of time for questions and answers. So how did we get here? ASCs have known that quality reporting is in their future since the passage of the Tax Relief and Health Care Act of 2006. This act required CMS to develop an ASC quality measure reporting system. It also imposed a penalty on ASCs that fail to comply. You may remember an outbreak of hepatitis C from that Las Vegas surgery center in 2008 that got a great deal of regulatory attention at both the state and federal level. That same year, the GAO, Government Accountability Office, issued a report that found there was no national infection control data available on ambulatory surgery centers. This only served to heighten CMS concerns about the quality and safety of the ASC environment. As we all know, this led to a dramatic expansion of ASC regulation and enforcement in 2009 and following. In November of 2011, subsequent to the issue of a proposed rule and comment period, CMS published the final rule for the outpatient prospective payment system. This is called CMS 1525 FC, final change. In that rule, in Section K specifically, it addressed quality reporting for HOPDs and ASCs. It identified 5 claims-based reporting measures. It also stated that reporting would commence in calendar year 2012, and that compliance would be based on reporting, not performance, and that noncompliance would result in a payment penalty from Medicare. So ASCs participating in the Medicare program as of January 1st, 2012 are obligated to begin reporting in October 1st of this year. We expect Medicare participating ASCs of October 1st to begin reporting January 1st of 2013, although this has not been formally published by CMS. There are 5 quality measures, and we're going to discuss them in detail. The measures were recommended by the ASC Quality Collaboration and approved by the National Quality Forum. This final change also stated that additional measures will be added in subsequent years, and we're going to talk about those in this webinar as well. So that was the information we had to work with until April of this year, when 2 important documents were published that further codified the ASC quality reporting mandate. The first, and this is one which everyone will want to download and review if you haven't already, is the Quality Measures Specification Manual published by CMS. This is a 20-page document that in essence is the user manual for ASC quality reporting. It provides the specifications for the quality measure reporting. It includes definitions, reporting periods, payments affected, quality data codes, and their appropriate use, etc. ASCs will be required to designate a quality net administrator to serve as the point of contact between the ASC and the site. And Kathy is going to talk more about the Quality Net website, so we won't go into that any further here. But the link to access the manual is right there at qualitynet.org. Also, in April of this year, the Inpatient Prospective Payment System Rule was published. And within this rule was embedded a section called Proposed Quality Reporting Requirements for ASCs. This section addressed administrative requirements, data completeness requirements, extraordinary circumstances or waivers, and a reconsideration or appeal process. And the link to access that document is there on the slide. Basically, this publication defined what will be considered compliance. It states that 50% of Medicare fee-for-service claims must include the quality data codes in order to avoid a 2% penalty in calendar year 2014 payments. It also stated that at least at the current time, there are no plans by CMS for validation through record review or any other means. This document also defined a process to request an extension or a waiver for an ASC unable to report due to extraordinary circumstances. And this could include, natural disaster or, any sort of extraordinary situation. It also states that there would be a reconsideration process. If an ASC believes that CMS has erred in assessing them as failing to report at the 50% threshold, the ASC has access to the same reconsideration process available to hospitals. The comment period for this proposed rule ended this week on Monday, June 25th. We expect the final rule to be published in late July or early August timeframe. And as Mike said, US is planning a follow-up webinar so that you can stay current with the most updated information, which will undoubtedly include whatever is in that final rule. One big unknown that we're awaiting more information on is the public reporting. We understand that this ASC quality data that's being reported will be made available to the public, but it's unknown at this time exactly what that will look like. We do not have proposed language on that at this time. So in summary, CMS wants quality data codes, or G codes, which we're going to review, on all Medicare fee-for-service claims. The reporting will commence October 1st. There are 5 quality measures, 4 outcome, and 1 process. As I said, we'll go through those in more detail. And the payment year affected is calendar for the reporting between October 1st, 2012 and December 31st, 2012 is the calendar year 2014 Medicare payments. And failure to comply at that 50% reporting threshold will result in a 2% reduction for payments in calendar year 2014. So let's drill down on the specific quality measures. CMS was kind enough to thoroughly define each one. The first is a patient burn. This is defined as an unintended tissue injury caused by any of the 6 recognized mechanisms: scald, contact, fire, chemical, electrical, or radiation. For us in ophthalmology, we could expect to see possibly a corneal burn related to the use of the phaco. If you're doing oculoplastics, there's the possibility with the use of cautery of the patient experiencing a burn that way. So those are the kinds of that's the quality measure related to patient burns. The second is patient fall, defined as a sudden, uncontrolled, unintentional downward displacement of the body to the ground or other object. The third is wrong site, side, patient, procedure, or implant. In 2009, CMS issued 2 national coverage determinations to protect patients from preventable surgical errors. You may remember they called those never events. And those included wrong procedure, procedure performed on the wrong part of the body, which would be site or side, and a procedure performed on the wrong patient. CMS considers these non-covered services and therefore does not reimburse an ASC. So these are reportable events under this new mandate. The fourth is a hospital transfer or admission, and it's important to understand that this includes any transfer or admission from an ASC directly to an acute care hospital, including hospital emergency rooms. So if a patient is transferred directly from the surgery center or discharged directly to a hospital, it would be included in this quality measure. The fifth measure is a process measure. The first four are outcomes. The fifth one is a process measure, and it has to do with timely administration of prophylactic IV antibiotic to prevent surgical site infection. So it is prescribed with the intent of reducing the probability of an infection related to an invasive procedure, and it has to do with timely administration. So if a patient has an order for an IV antibiotic preoperatively for another reason, for instance, mitral valve prolapse, that is not what is being reported in this particular measure. It's antibiotics ordered and administered specifically for the purpose of reducing surgical site infection. So these 5 measures are going to be claims-based reporting measures. We're going to report using quality data codes, or G codes, on the CMS 1500. So now we're going to look at the specific codes and exactly how the codes are reported. This is the code we're probably going to use most often. This code is used when a patient does not experience any of the 4 outcome measures. As you remember, we just reviewed 5 quality measures, 4 outcome and 1 process. So the 4 outcome measures, if the patient does not experience a fall, a burn, a never event, or a hospital transfer or admit upon discharge, then you would report using this code, G8907. That means the patient is documented not to have experienced any of those following events. For a patient burn, there is a specific code to use if the patient did not receive a burn prior to discharge. There's a code to use if the patient was documented to have received a burn prior to discharge. Or if the patient did not receive any of the 4, fall, burn, never event, hospital admission, or transfer, you would use, again, the G8907. So as you can see, relative to each of these first 4 quality measures, there is a code to use if it happened, a code to use if it didn't happen, or there's a code to use of if none of the above happened for all 4 of them. Patient fall, it's the same way. G8910, if the patient did experience a fall, G8911 if the patient did not, or if the patient did not have a fall, a burn, a transfer admission, or a never event, you would use G8907. Again, the same for the never event, wrong site, side, patient, procedure, or implant. There's a code to use if it happened, a code to use if it did not happen, or a code to use if it was none of the above, the G8907. And the same for the hospital transfer or admission, G8914 if the patient did experience the transfer/admission, 8915 if they did not, or G8907. Now, the process measure of the prophylactic antibiotic timing has been a little bit confusing. The ophthalmic community is still working, and USE is actively working with other industry leaders with CMS to seek an exemption for ASCs that do not perform any procedures that require prophylactic IV antibiotic for surgical site infection. However, as of now, all ASCs are required to report on all 5 measures. So you cannot ignore this one. Definitely stay tuned to USE for updates in the future if the requirements change. But as of now, there are 3 codes related to the prophylactic IV antibiotic timing. G8916 states that the patient had an order for a prophylactic IV antibiotic for surgical site infection, and it was initiated on time. G8917 is that a patient had an order for an IV antibiotic surgical site infection prophylaxis, but the antibiotic was not initiated on time. And G8918 is that the patient did not have an order for an IV antibiotic for SSI prophylaxis. So unless this requirement for us to report as ophthalmic centers on this particular quality measure changes or goes away, the vast preponderance of the time or all the time, we would be using G8918. That is, that the patient did not have a preoperative order for IV antibiotic surgical site infection prophylaxis. So what is this going to look like for us? There are a few things, important points to remember on the claims submission, and I think just as a way to kind of make it easy, what I'm telling people is it's 2 or 5 when we go live. If there were no events, none of the first 4 outcome measures occurred with the patient, we'll use the G8907, and then we would also still have to use the code for there was no order, the G8918, that states the patient did not have an order for IV antibiotic surgical site infection prophylaxis. So at a minimum, if there was nothing to report, you would need those 2 codes. If there was an event, you would need to use 5 codes, because you would need to use the code that stated, for instance, that the patient had a burn. And then you would have to use the code that stated the patient did not have a fall, did not have a never event, and did not experience a hospital transfer or admission. You would also have to put in the code for the prophylactic IV antibiotic, that the patient did not have an order for IV SSI prophylaxis. So it's either going to be 2 or it's going to be 5. You will need a charge field for the quality data codes. The charge field cannot be blank. Ideally, the line item should be 0.00. However, many people are reporting that their systems will not allow them to submit a claim that has a code with a 0 charge. So some nominal amount would need to be substituted. As you can see on here, it's 1 cent, 0.01. CMS will not accept a claim with a 0 charge. If the entire claim is a no-charge claim, it will be rejected. Therefore, if you submit a claim forgetting to include the quality data codes, you cannot resubmit for the sole purpose of submitting the quality data codes. If you have a claim that's denied or rejected for another reason, you may resubmit with the quality data codes or with corrected quality data codes. That basically presents an opportunity for you to resubmit and to comply with the quality data code reporting. CMS does not consider a claim closed until it's paid. So if it gets kicked back to you for another reason and you have to resubmit with including the quality data codes. This slide summarizes the 2012 quality measure reporting requirements. Besides the 5 outcome and process quality measures that we've discussed, there are 2 structural measures that have to be reported for the calendar year 2012 in order to avoid payment penalties in 2015. As you can see on the slide, the reporting between October 1st and December 31st of 2012 would affect your payment in the calendar year 2014. For the structural measures, the use of the Safe Surgery Checklist and the procedure volume data for calendar year 2012, the reporting is going to actually occur in 2013, and it would affect payment determination in 2015. Remember, as long as you report the required data within the specified time frame, you will be in compliance with the quality reporting mandate and receive the full annual update to your payments, regardless of the outcomes. As I stated earlier, at this time, the report, this is not payment for performance. It's payment for reporting, at least at the current time. We are not being, there is not an expectation of achieving a certain performance standard within the quality measures. Could that come down the road? Certainly, but that is not the way that the current requirement is specified. Another important thing to note is that penalties for failure to report are not cumulative. For instance, if an ASC fails to report in 2012, they would be penalized in 2014. However, if they met the reporting requirements in 2013, they would not be penalized in 2015. So the penalty is over the course of a year, but is not cumulative year over year. One of the structural reporting requirements is procedure volume data. CMS has determined that based on evidence that the volume of procedures, particularly high-risk procedures, is related to better patient outcomes, and they want to capture all patient data on these particular measures. They're not the first five. The process and outcome codes, quality measures that we discussed, are just for Medicare fee-for-service patients. You're going to report those on a CMS 1500. But this procedure volume data procedure volume data requirement is for all patients or all procedures performed in your surgery center. So reporting for 2012 cases will be done by each center between July 1st and August 15th of 2013, and this is going to be reported through the QualityNet website, which Kathy's going to talk more about. Medicare has identified procedures by code in these areas: GI, eye, nervous system, musculoskeletal, skin, GU, cardiovascular, and multisystem. For the purposes of this presentation, we're just going to focus on the eye codes. So this is a list of the procedure codes that we need to track and report the volume on each of these codes for the calendar year 2012 in that reporting window between July 1st and August 15th of 2015. All of the reportable codes are listed on page 17 of the Quality Measures Specification Manual. The manual is the one I referenced earlier. It's available at qualitynet.org, and it's included in the list of references and resources provided at the end of this presentation. The second structural measure is influenza vaccination of healthcare workers. The reporting period for this is going to be 2014. October 1st through March 31st of 2015, and it will affect payments in calendar year 2016. Note that we have to report on all all staff and employees, all medical staff, students, and volunteers. And the reporting is going to be through the CDC website. And the link for the reporting portal is right there on that slide. And now I'm going to turn it over to Kathy, and she's going to talk about tools, resources, implementation, and internal processes to be able to comply with this new mandate.
Thank you, Regina. Now that we have the background information, which is a lot of information to digest, we thought it would be helpful to talk through some tools and resources to help you actually get ready for the various aspects of reporting. As mentioned at the beginning, we do have documents that can be downloaded. These can be found in the green file folder at the bottom of your screen. And those do include a copy of this presentation. And I'll be referencing some of those documents as we go through the next few slides. So we're going to talk about what education is needed, some basics about the Safe Surgical Checklist, quality data codes, procedure reporting, and touch on influenza vaccination. So staff education, it's really important that everyone at the center understands what this is all about and what their role is in it. So starting now, it's important to conduct education with your staff, your physicians, and your governing body. You can use these slides. You're welcome to use the slides from this presentation as a basis for that education and then adapt them to your center. Some of the topics that would be good to include are, why do we have to report these measures? Basically, it's a CMS requirement. It's becoming a CMS requirement. There's going to be a payment penalty involved starting in 2014. It's preparation for pay for performance, although it's right now just pay for reporting. The measures in some way are going to be publicly posted. As Regina mentioned, we don't have the final rules for that yet, but we do know that something will be posted. And it's a patient safety issue on some of these measures. So if the staff can understand the time frame for the requirements, they'll understand how fast this needs to get done. Include an explanation of everyone's role in gathering the required documentation. And it perhaps is a good idea to consider doing a pilot or a trial run of the measures as applicable to each specific measure. So with regards to data submission to QualityNet and NHSN, as you can tell from the information that Regina shared from us, we do not have all the specifics and all of the rules for our reporting yet. But as of right now, the QualityNet website through CMS is where reporting will occur for two of these measures that are not claims-based. And that is being set up for ASCs. It is not complete at this time. CMS is telling us that they anticipate that that access will be available in January of 2013. And remember that nothing actually has to be reported until July of 2013. So for right now, it's a good idea for each center to consider who will be the system administrator and the person responsible for registering the center on these websites and for entering the data. You can, for right now, monitor progress on the CMS QualityNet website. They do have a tab set up for ambulatory surgery centers, but no registration or site available yet for us to register. The second website, where we will ultimately be reporting flu immunization, is NHSN, which is the National Healthcare Safety Network. And this is a website within the CDC site. The surgery centers will be registering on that site and using that to report the influenza immunization starting in 2014. OOS, the ASC Association, and the ASC Quality Collaboration will all be monitoring progress on the details of this reporting. So let's talk a little bit about the surgical safety checklist. This is based on evidence that the surgical and procedural complications are reduced when a safe surgery checklist is used. We've been familiar with the use of a timeout for many years, but this expands the timeout. It reduces the potential for human error and is really intended to prompt verbal communication among the surgical or procedural team. And the requirement for this is based on work done by the World Health Organization as part of their Safe Surgery Saves Lives campaign, which took place in 2009. So for this measure, each center will, after they've registered in QualityNet and during the reporting period that Regina mentioned, which starts next July for a 45-day period, each center will go in and will only have to answer yes or no for the time period of 2012, and they have to state yes or no whether a surgical safety checklist was used at any time during 2012. This measure changed when the specifications manual came out. Some of you may have heard that we were going to have to go in and state yes or no that it was used on all cases, but they changed the verbiage in this measure. So it's now just whether one was used at any time during 2012. I think it's important to remember that the effective use of a safe surgical checklist really has had an impact on wrong site surgery. And Regina talked about the wrong site surgery measure. It's particularly critical in ophthalmology because of the lenses, and it relates to blocks. So if there's a wrong block done, that is also considered a wrong site surgery. Just wanted to point out again that the use of this checklist is based on research that's been done. In a pilot study for the World Health Organization checklist, it was found to reduce the rate of post-op complications and death by more than 1/3. So a substantial impact by the use of a safe surgical checklist. There are really only 3 mandatory components to the safety checklist that have been outlined for the ASCs, and these are prior to administration of anesthesia or sedation, prior to the incision or the start of the procedure, and prior to the patient leaving the OR or the procedure room. So what does the surgical safety checklist look like? There's really no mandated form. So each center can develop theirs based on what their patient flow process is. Some of the options are it can be a written checklist that's put in each chart to be used in the procedure room. It could be a template checklist that is the same for all cases and is posted in each room, say on a laminated sheet or a whiteboard, to prompt communication. Again, it's really important to remember that this is not meant to just be a checklist that you go in and check off. It's meant to prompt the verbal communication among the members of the team. It can be integrated into the electronic medical record as long as the required documentation prompts that verbal communication and it's not just a check off within the EMR. It can also be integrated into a paper medical record. So each center needs to look at it and match it up with their process, look at the mandatory components, and develop their own checklist in their process. Some centers already have a checklist that they're using that actually fulfills the requirements. So what I wanted to do is provide you some samples of checklists in case you don't have one developed already. This one is actually a checklist for cataract surgery only that has been adapted from the World Health Organization checklist. And this was developed for use in the hospital, so it has some measures that we do not use in the ASC setting. But in your templates, it's there in a Word document, and it can be modified. Obviously, it would be a much simpler document in the ASC setting, but it's there for your use, and it can be modified. The next one is just a sample of an ophthalmology safety checklist for use in an ambulatory surgery center. And again, you can't read all the verbiage on the screen, but it is in the templates. But it covers the areas of prior to anesthesia. Then the next section actually includes the actual timeout. That's the middle section. And then before the patient leaves the room is the last section in the red. This really is intended to address all the phases of care within the OR and procedure room. So if you have a pre-op process for verification, that's separate and apart from this checklist. This is really intended for the steps that take place in the operating room or the procedure room. So those samples are there for your use if you don't have one started yet, or if you just want to take a look at those. There are other samples that are also available by various organizations such as AORN that can be modified for the ASC setting. So turning to the quality data code information, what we have to do is be able to transmit the information about these patient care events, such as the burns, falls, wrong site surgery, and hospital admits, to the coders and the billers. So this information may be captured in an electronic medical record, but most of the vendors are really still in the process of setting that up. So you may need to check with your EMR vendor and see where they are with integrating this into the system. You may need to develop a data information sheet that is attached to the chart to follow the patient through their stay, and then transmit the clinical information to the coder and the biller. And this is the approach that most surgery centers are going to be using, at least to start with, until it is set up electronically, if they're able to do that. So this, again, is just a sample sheet, and it's in the template documents. But this is a data sheet that we developed to follow the patient through their stay, and it includes all of the codes and a place for the nurse to initial in case the coder or the biller has to go back and ask any questions about the documentation. And it also includes the definitions of the measures. So you may or may not need those definitions. The ASC Quality Collaboration actually has used those definitions and developed those measures, and their implementation guide on their website, which we have referenced later, contains all the definitions as well. But we included those because there may be times that you're questioning, well, is this reportable or not? For example, patient fall, the actual definition is that the fall occurs within the walls of the ASC. So if a fall takes place out in the parking lot, it's not reportable. A lot of questions also about hospital admits. The hospital admit measure includes patients that go from the pre-op area after they have registered. So it's important that the nurses understand these measures. And those are included there. So the next issue is the volume reporting, and it's going to be necessary for all the centers to track all of those reportable codes. Any of those codes, Regina included, that are I codes that are reportable for calendar year 2012. You will need to compile a report for those procedures that were done in 2012. And it may be a good idea, if you have the ability to run an internal trial report prior to the end of the year, it can just give you a feel for what that report may look like at year end. Then, as we mentioned, you will register on QualityNet probably in January. We're assuming that will take place in January, and you will hold that report with your volumes until the reporting period begins in July. And those volumes, those total volumes for those procedures will be reported via QualityNet. And those are for all payers, not just Medicare. So Regina mentioned the flu vaccine, and this one is not top of mind right now like the quality data codes are, but it is included in the measures, and it's important that everyone is aware of it. The actual specifications for this measure are not yet final. We do know that it will begin, the measurement of it will begin with immunizations for the 2014 flu season. And it is apt to include both your employees, your physicians, students, and volunteers. That is the group that they're calling healthcare workers at this point in time, but again, we're waiting for the final specifications. One suggestion is to actually begin internal tracking of your immunization rate for this flu season in 2012 and for the flu season of 2013 before it becomes mandatory. It'll be important for you to know about where you are, about what percentage of your staff is vaccinated. I know there are some states, Colorado has issued regulations that you have to report the actual percentage to the state. So we're seeing more and more states develop measures related to this. Important to conduct staff and physician education regarding the flu vaccine and the importance of everyone receiving it. And there's great information available on the CDC website that can be used for education. This is just a sample of the educational material from CDC. You can even just do a little fact sheet that includes the information off of that website. The other thing that is included in your template documents is just a sample of an employee tracking log so that you can track how many of your employees have received the vaccination and come up with your percentage for like this flu season. And again, for just an overall measure for trending and the ability to be able to look at the reasons why people aren't getting vaccinated. So just some template forms. Certainly don't need to use these, and it's not required in any way by CMS until the flu season of 2014. Regina mentioned the specifications manual, and yes, I would highly recommend that if you don't have that printed out that you do so, because that really is what came out with the final rules as they are now. We have some issues that Regina mentioned, for example, what the definition of completeness is that are still pending and have been out for comment. So there will be more information coming, but this is the basis of the how-to manual for the quality measures. Some of the other resources that are available here are listed here. I mentioned the ASC Quality Collaboration, and their implementation guide includes the actual definitions of the measures. So with that, I believe we're ready for questions.
Thank you, Kathy. The first one, Kathy, if you could respond. The question is a safe surgery checklist required for GI cases or only for surgical cases?
It's required for all cases, and the GI cases, it is a little bit different because just of the way of the procedure, but it is required. It can be a rather simplified form, and if anyone's interested in seeing a GI sample, my email address is at the end, and I would be glad to supply that.
Thank you, Kathy. The next question is a minimum of 3 entries on the HCFA form would then be 66984, G8907, G8918 for most cataracts without any problems. Is this correct? Yes. When I came up with that little mantra 2 or 5 when we go live, it was really in response to, it was just addressing the G codes, the quality data code set. Obviously, you still definitely need to put your procedure code for which you're billing Medicare. So you would have your procedure code, and then it would be either 2 or 5 of the quality data codes. The next question is, Kathy, can you answer? Are all patients expected to receive a pre-op antibiotic?
No, not all patients are expected to receive an antibiotic. That is really only intended to capture for those patients for which is indicated and ordered whether it was administered in a timely way. So that last category under timing of prophylactic antibiotic is the one that that the eye centers will be using most, and that is a patient without a pre-op order, which also equates to a patient for which it is not indicated.
Thank you.
And I will say that we have most of the industry organizations that have responded to the comments on the additional rules have asked that more clarification is issued with regards to centers for which this is not appropriate. So we're still hoping that they may clarify that. There has been some confusion about that measure and whether eye centers and GI centers would even have to enter something there, but we got the answer back at yes, they do.
In a related question, Kathy, is if anesthesia gives the antibiotic and not a nurse, would there need to be an order for it?
Yes, there still needs to be an order for it, a physician order for it.
Okay. And you mentioned it, but just to reiterate, in your, I know you mentioned it in your presentation, Kathy, but about wrong side anesthesia blocks being included as never events, just to underscore the importance of that. Yes,
really important that wrong blocks are included in that measure. And we've certainly seen, especially across eye centers, that becomes an issue, and you really do need to be doing the equivalent of a timeout prior to a block to make sure that it's all the same parameters are met that are specified. Very important, and it's a good question.
Okay. And another question is, it looks like the only procedure code for endothelial corneal transplant is listed. Do we include all corneal transplants or just the endothelial type? The procedure volume data requirement is specifically on the procedure codes that CMS has listed, and those are in that quality measures specification manual, and they're also in the slides. So only volume data reporting on those specific CPT codes that were listed in that slide and that are in the manual are what are required. I do want to mention that with respect to the surgical safety checklist, Kathy mentioned that there are other safety, other sample checklists available, and just this week, the Academy, ASCRS, and OOS have issued a sample ophthalmic safe surgery checklist.
Yes, so I should have mentioned that, yes. Mm-hmm.
And so that checklist is available on either of those three sites, the Academy of Ophthalmology, the ASCRS, or OOS.
Yes, great, thank you.
And Kathy, wrong site eye drops in pre-op, is that included in the wrong site reporting?
That's a very interesting question. The ASC Quality Collaboration is looking at that now, and we polled all the centers that participate in their quality reporting, and right now the conclusion that we reached is that if eye drops are placed into the wrong eye by a nurse, that is counted as a medication error rather than the wrong site, assuming that it was caught then and the correct procedure was done.
Okay. And there are a number of questions related to antibiotic eye drops or ointment. Does this have to be reported?
No, it does not. This is only intended for IV antibiotics for the prevention of a surgical site infection.
Thank you. Another one related to the safe surgery checklist, Kathy. Does the safe surgery checklist have to be on each chart?
No, it does not. Again, you can adapt the safe surgical checklist for your setting. Some centers have opted to just post the safe surgical checklist in the OR. It prompts the verbal communication at those steps during the patient being in the room. And I do think it's a good idea to just document in the chart somewhere that the safe surgical checklist and timeout were completed. CMS has said they're not going to come back and review individual charts to see if that's in compliance, But just from a good documentation perspective, it's a great idea to just put that was completed. But no, it does not have to be in every record.
Okay. Hopefully we've clarified the issue about the antibiotics. We have still a number of questions, but I think you've already addressed it. The only antibiotic reporting requirement is related to IV antibiotic prophylaxis ordered for surgical site infection.
Correct.
So the drops, the ointments, the intracameral, all of that, there is no quality measure or quality data code or reporting related to those antibiotics.
Correct.
That we routinely use in ophthalmology.
Yes, no, it is not required for those.
Okay.
And this is really more aimed at true surgical site infections and research that has been done to show that the timeliness of the administration is important to its efficacy. So that's really what that is aimed at, and it does not relate to any other type of IV antibiotic administration.
A couple of questions, Kathy, related to hospital transfers or admissions.
Yes.
The first, if a patient requires a transfer prior to surgery for a non-surgical related issue, for instance, elevated blood pressure or AFib, would this be reportable?
Yes, it is reportable. And even though that should not reflect badly upon the quality of care that's given by the center. In fact, it's just the opposite. It reflects that very appropriate and good care is given. Once that patient is registered and back in the pre-op area, if they are transferred, it counts in this measure.
Okay. And a second question related to that is when reporting hospital transfers, admissions, is that all patients sent to an ER or just the ones sent via ambulance?
Good question. It also includes patients that go just to the ER, that are sent to the ER upon discharge from the center.
Okay. And is
and
hospitalization
also,
due to blood pressure problems a yes, or does it just relate to post-op eye problems?
I'm sorry, I missed that.
Is hospitalization due to blood pressure problems a yes, or does it just relate to post-op eye problems?
It would be for any type of issue.
Okay, thank you. There's a question about where the quality measure specification manual is available, and it's at qualitynet.org. It's also the link is in the slide and a couple places in these slides, so you shouldn't have any trouble accessing that. There's also a question regarding the never event, and just to clarify that includes wrong site, side, patient, procedure, or implant. So the implanting of the wrong IOL, the wrong diopter, the wrong
yes.
would also be a reportable event under this requirement.
Yes, it is. Mm-hmm.
Okay. Another GI question for you, Kathy. Just to clarify, for GI cases, the G8918 code would be used for patients with no IV antibiotics ordered, and also the GI patients GI patients that have an order for IV antibiotics, since it would not be ordered for the prevention of SSI.
Right. So if it's ordered for other reasons, that's a good question. If
Exactly.
that's ordered for other reasons, then it's not in this measure. And that's correct. That most GI, it's going to be that there's not an order because it's not applicable.
If a patient is canceled for blood pressure or elevated blood sugar and told to go to their family physician rather than the ER, is that reportable?
No, it's not.
Okay. And I think once you all take a look at this quality measure specification manual, you will see that this is spelled out very specifically in terms of defining what's reportable and what's not. We have another question related to hospital transfer. If you report a transfer to a hospital during pre-op before going to the OR, how would this be billed? No surgery codes are reported in this situation. In that situation, you would not report.
That or a Medicare patient. Yeah. Do you need to just put the?
Yeah. My understanding is that Medicare does not pay. These are for billable Medicare fee-for-service patients. So, and that's actually a question, that's a good question, and it's one that I've asked for clarification on. And my understanding is that if you do not have a billable transaction with Medicare, you don't report just for the sake of reporting. You report on billable procedures. So
yeah, that's a good question, right, that we still need the answer to definitively.
Right. That's the way that I had it in. I actually had that conversation just last week with the ASC Association. And on a lot of these questions, I mean, they're good questions, and since the specifications manual was published in April, a lot of these questions have been raised. Some of them we have answers to definitively, and others, we're still waiting for that final rule. And that's why, as Mike mentioned, there will be another webinar sometime later in the summer, early fall, to be able to clarify the outstanding issues. A question related to quality data code reporting is only for Medicare patients, correct? No Advantage or commercial payer claims? That is correct. At the current time for 2012, the quality data codes are to be used for Medicare fee-for-service patients only, not Medicare Advantage. Another one for you, Kathy. A patient is transferred prior to anesthesia is billable. Oh, sorry, this will probably be for me. Is billable with modifier 73 and payable at 50% by Medicare. As I said, if there is a billable code being transmitted to Medicare, then you would include the applicable G codes. But if it's a zero amount claim, if it's a zero claim, you would not submit a claim just to submit quality data codes. For clarification in regards to the lens or diopter, does this pertain to the lens model or power or wrong lens implanted? Kathy, you want to take that one?
Well, when you actually read the measure, it reads something that is done differently than the intended procedure. So if a patient, you have to look at obviously what is planned and what is pulled for that patient and what has been ordered for that patient. And if what is ordered is not placed, into the patient, now that's not to say that sometimes it doesn't get changed before it goes in and they end up with the correct one. But if there's an error that's resulted in that patient getting the wrong any of those, then it would be reportable.
There's a question, is volume data for primary procedures only? Volume data is on all of the procedure codes listed in the quality measures specification manual. So if the procedure was performed, whether a primary or a secondary procedure, it should be included in your volume data reporting. That's our understanding, at least at the present time.
Right, and we included that question in the comment letters that went back because it wasn't made very clear. So hopefully there will be more information coming out about that. But that's a good question.
Okay. Are facilities placing a checklist in a patient's chart for each area nurse to check off that the events did not occur in their area? I think you addressed this earlier, Kathy.
Yeah, that would be just the worksheet that you have travel with the patient through their stay so that the nurses can indicate if any of those events occurred. that's different than the safety checklist. Two different, pieces of information.
Right. Sorry, I'm just scrolling through these questions here. Here's a scenario. One backup lens is available for a procedure, but the doctor needed a third lens, but unavailable, so had to use a different diopter. Is that a never event?
I'm not sure I can answer that.
So they had my understanding of this question is that they had a primary lens, which for whatever reason they decided to go to their backup lens, and the backup lens was not available in that diopter, so they implanted a different diopter.
It sounds like if the physician ended up wanting that diopter for that patient, that would not be reportable. That's just a different scenario than he wanted that one and the wrong one got pulled.
Yeah, I think that is one that probably, hopefully we'll get clarification on. I mean, as you said, it's other than intended. In my experience, most of the time a surgeon will communicate a primary and a backup lens to the surgery center. And it's our obligation and responsibility to have both available. So if the backup lens that was requested in the IOL order is not available, then we're implanting one other than what was intended.
And it indicates a process problem, right?
Exactly.
Yeah, and that's kind of the key to it too. Is if you can track this back, to a process issue, that's usually will answer the question. So yeah, that one would be debatable, I would say.
Okay.
And we may be able to get more clarification. I think certainly as these start getting reported, CMS will need to respond to, these types of questions as these things arise.
Exactly. Just to clarify, the next question, only the 21 codes listed for ophthalmology are the only codes we have to report these measures for, not all eye codes. Okay, just that I'm a little confused by that question, but I'm going to try to clarify. The first 5 measures, the outcome, the 4 outcome and 1 process measure that we discussed that have the quality data codes assigned to them, have to be reported on all billable Medicare fee-for-service claims. The procedure volume data is reported on all patients, not just Medicare fee-for-service, all patients. You need to report what is the volume of those procedure codes that you delivered for the calendar year or for the year 2012, and you're going to be reporting that during that reporting window through qualitynet.org next summer from July 1st to August 15th. So the quality data codes apply to billable Medicare fee-for-service patients, but the procedure volume data applies to all the procedures done in your facility if there are codes that are listed in the specifications manual. So
right, and I think, Regina, you mentioned this, but if you think about the intent of that volume reporting, what they did, and they changed that list up from the original proposed rule, they were trying to get at procedures that are most representative of procedures that are done in an outpatient setting. So it really is just a subset for each specialty. And the thinking being those are the ones that are done most frequently, and a patient would be able to go out onto a website and see how many of those each facility has done in comparing facility to facility, and potentially hospital outpatient to an ASC.
Kathy, is the safe surgical checklist required for YAG lasers since anesthesia is not used?
Yes, it's required for all cases. And again, that's an example of one that it could be an abbreviated form that you use for YAGs.
Okay. We have another procedure question here about primary and secondary procedures. I think we addressed that. is this also for YAG laser done in the ASC? I think you've addressed that. Did you say that antibiotics given for mitral valve patients, et cetera, do not have to be reported?
That is correct.
This is for
cardiac
surgical
reasons.
Site infection prophylaxis only, correct?
Yeah, and for cardiac prophylaxis, that's not included.
For volume reporting, if a patient undergoes 2 procedures during one encounter, cataract and pterygium, is this considered 1 or 2 procedures? If it is one of if the 2 procedures are procedure codes that are listed as volume data reportable, it's 2 procedures. If a patient is discharged from the ASC and told to go to the ER but not transferred via ambulance, is that reportable?
If they go directly to the ER, it's reportable. If it's do not pass go directly to the ER, even if they go in the car, it counts. It should be reported.
Okay. Did you say, sorry, let's see. What do you recommend if we do not have EMR?
If that's with regard to the Safe Surgical Checklist, you can use a paper form or post it in the room. And if it's with regard to capturing the quality data code information, I would advise that you use a sheet that follows the patient through, that the nurse can indicate which code, and that is then transmitted to the coder biller.
There's a question here, what is meant by wrong IOL? The way it's defined in the specifications manual, as Kathy said, is other than what was intended. And one of the scenarios that I raised specifically was the surgeon orders the IOL model and diopter. We implant the IOL as ordered, and then sometime in the next week, the surgeon determines that for whatever reason in his record keeping, he got it wrong. And we bring the patient back and we exchange the IOL. Would that be reportable as a never event on the first procedure? And what my understanding is, in that situation, we implanted the IOL that was intended. That's the IOL that was ordered. That's the IOL that was documented. And we obviously, as Kathy said, they're looking at process, and do we have the processes in place to assure safety and accuracy for the patients? And in that case, we did everything we could, and we implanted the IOL that was intended. If the surgeon determines after the fact that they had a calculation error or for some other reason they got it wrong, that's not something over which we would have any control or any knowledge of.
Right.
Some of our patients are transferred to urgent care. Would that be considered equivalent to sending a patient to the hospital if they didn't get admitted?
Urgent care is not included in that.
Okay. Do I report the influenza vaccines our center gives to employees, or even if they get it from their PCP?
Yes, it'll be important for you to be able to get some documentation from employees that they've gotten it, even if it's not a vaccine that you're administering.
With regards to the flu vaccine, does it mean all staff need to have a vaccination, or only staff in direct contact with patients?
Again, this is a measure that we're waiting for the specifications on, so we don't know if it's going to be direct patient care, but as of right now, if we look at the measure, it does include all staff, including business office staff.
Okay. I think you covered this. How do you address if the anesthesiologist gives a block and it's the wrong eye? Is that reportable? I think you addressed
Yes.
that. Mm-hmm. Okay. Do we need to report elective laser surgeries such as LASIK?
Yes, depending on which measure you're talking about. if it's Medicare. I mean, some of these, the quality data codes only relate to Medicare patients. But a wrong site would be reportable.
Most of the Medicare patient claims go to HMO because they have HMO Medicare rather than Trailblazer. Are they reportable? No. At the current time, the quality data code reporting is only on Medicare fee-for-service, not Medicare Advantage patients. On the topic of transfers, Kathy, of post-op patients, is this only for emergency rooms, or do we have to follow up with primary physicians for the next 36 hours?
Transfers are to an acute care facility. Regina, it looks like we are getting down to the end of our time. I do want to let everybody know that we will have a copy of the questions and the contact information so that if a question's not answered, we will have the ability to get an answer back to you if we have it, if the information that we have answers your question. We'd be glad to do that.
Kathy, I think one more that you might be able to just respond to quickly is, how are the billers and coders obtaining this information without having to go through the whole chart at the end of the day?
They're doing that by use of the data code sheet, the sample sheet that we provided, so that they don't, because they were not going to be able to, always find that information in the chart. That's kind of a cheat sheet that we're providing to them from the nurses, from the clinical staff, those that have taken care of the patient all the way through. It'll be indicated on that sample sheet when any of those codes occur.
And one other that's related, can we add the quality measure information to our regular paperwork, for example, on our PACU form for IV antibiotic administration?
Absolutely. Mm-hmm.
Okay. Well, I think that concludes our session. I think we're out of time here. Mike, I think you've got the wrap-up. Perhaps not. So we want to thank you for joining us. We hope that you found this informative and helpful. As we said, it's still an evolving situation. US is staying very close to it and on top of it, and we'll be having a follow-up webinar sometime in the next couple of months to bring you up to speed on the latest once the final rule is published and we have even further clarification on these measures. So again, we want to thank our sponsors, AmSurg and Hoya, and of course US for taking the initiative to bring this important information to their membership, and to Ophthalmology Management for facilitating this great session. The slides are available, and the session will be available on demand after this meeting. Some of you have sent in questions that your administrators, some of your staff members weren't able to attend, so you will be able to access it after its conclusion. So again, thank you very much. Our contact information is in the slides. If you have further questions, don't hesitate to email Kathy or me or Mike at US. Have a great day.